There we go. All right, so chapter 22, diabetic emergencies and altered mental status. So we're going to go over tonight the pathophysiologies, assessing a patient with altered mental status as well as diabetes, and causes of other mental status changes as well. So pathophysiology. Our mental status is all regulated by what we call the reticular activating system, otherwise known as the RAS. So the RAS is responsible for staying awake, paying attention, and sleeping. Brain tissue of the RAS has some basic requirements, and if those requirements aren't met, we start having things like altered mental status. So we have to have these three requirements to have a solid, stable mental function. Okay. Oxygen to perfuse the brain tissue. And that's something across the board, all of our organs, regardless of whether or not it's muscle tissue, an actual organ like, say, liver or skin or brain, all of our tissues need oxygen to do their jobs appropriately. Glucose. Our brain needs glucose to function. In fact, it's one of the most sensitive organs to glucose. Now, I'm going to say it one more time because it might show back up on an exam, but the brain is the most sensitive to glucose changes in the body. All right. The next thing our brain needs is water to hydrate the brain tissue as well. So if we have a patient that's severely dehydrated, it's quite possible that it's going to affect their RAS, and then we're going to have some lasting altered mental status because of it. All right. So any deficiencies within those RAS requirements, oxygen, glucose, and water, we can start having some altered mental status. Any sort of trauma, infection, or chemical toxins can also alter our RAS as well. So think about this a little bit. If somebody gets a traumatic brain injury, they start getting some different alterations depending on where that injury was at in their brain. But one thing we see really common with these patients are like short-term memory loss as well as repetitive questions. They'll kind of stick to, 3 questions and ask them over and over again. Okay, very classic with brain trauma. Infections. Things like sepsis or infection right in the brain tissue can certainly cause issues with mental status. Chemical toxins. So this can be something that they've inhaled because, say, they came across it like carbon monoxide or different fumes that they're coming across, or maybe it was intentional. Maybe they injected a whole bunch of heroin into their bloodstream and now they're having a reaction to it, whether it was what they wanted or not. But those chemical toxins can certainly affect the mental status of our patient. Primary brain problems, as well as problems within other body systems, eventually they kind of start this domino effect and can lead to altered mental status as well. Okay. Altered mental status is often rapidly correctable by treating whatever that underlying cause is. For example, say it's a problem with low blood sugar. Guess what? We can fix that. We can give them additional sugar, or we can give them glucagon to help elevate their sugar, right, and hopefully correct that problem. So assessing a patient with an altered mental status. Safety is always a huge concern with these patients. Huge concern. Okay? In these instances, it's not necessarily that all of our patients that have altered mental status are going to be aggressive, right? It's not necessarily the case. But all of our patients that have altered mental status have the potential to be unpredictable. And it's that potential to be unpredictable that causes that need for additional safety measures on our part, making sure that we're not rushing into anything too quickly. All right. Did I freeze again? Are you kidding me?
No, you've been fine for me.
No? Okay, I literally just... Okay, Sarah just mentioned, are you frozen again? Okay. Oh, a little bit of an aggression on my part. But this internet, between the school's internet going out and my internet going out, it has been quite the week already, and it's only Tuesday. Okay. Back on topic here. So consider your safety, your crew's safety when entering into these situations. Use law enforcement when necessary. I will say, depending on the situation, law enforcement can either be helpful or they can be a hindrance, and it's up to you in the situation to kind of determine whether or not they're going to be helpful. I've called law enforcement to scenes several times, and I've just said, hey, we're not really sure how this is going to go. You know, they're a bit altered. Maybe they've got a lot of alcohol on board, or maybe it's even like a dementia patient. We don't know how this is going to go. Do you mind just kind of hanging out, taking a back seat for a minute until we figure out how this is going to roll? And they are more than happy to do that anytime I've had them involved in the situation. All right. We should always consider that possibility of airway or breathing problems with patients that have altered mental status. This is something, you know, I'm sure we've all maybe experienced this just throughout our lives, but you notice, you know, somebody that's maybe, well, I guess we've got a couple of people under the age of 21 in this class, but if you've ever been with somebody that's maybe drank a lot of alcohol, right, went out and celebrated and drank a lot of alcohol, eventually they probably either pass out or fall asleep on the couch or whatever, and they almost always start snoring, even if they're not typically patient or people that snore. That snoring is caused by the tongue relaxing and partially occluding the back of the throat. So it's a partial airway obstruction from that medical side. That's caused by the amount of alcohol in their system causing kind of a relaxed mental state, okay? Airway obstruction here, okay? So in those situations, oftentimes if we get called to them from an emergency standpoint, we're going to put in an NPA in our patients, or we're going to do our jaw thrust maneuver to indirectly lift that tongue up off the back of the throat, right? Okay. We should certainly be looking for any signs of inadequate breathing. Be alert to need for positioning, suctioning, consider administration of high oxygen, of course, if we think our patient is going to be, you know, hypoxic or they are hypoxic, right? But certainly just repositioning the airway, giving that additional oxygen is a really good place to start with these patients. Determine baseline mental status for our patients as well. So if we walk into a situation and they're not able to tell us what year it is that normal for this patient? Are they, you know, typically a bit confused on the year? Or maybe you ask them, hey, who's the president, or what day of the week is it? Well, president's one that, you know, at this point, because we didn't just switch one, they probably should know what it is. But again, you never know. Maybe it's something that they absolutely don't pay any attention to. Same thing with day of the week. I used to work nights. I had no idea what day of the week it was. I knew if I had to work, but I didn't know if it was a Tuesday or a Wednesday or what. Okay, so try and come up with a question that might be a little bit more relevant to the patient, like what big holiday did we just have, or what holiday is next. Those are pretty good ones. Other things like, what did you have? What was the last thing you had to eat today? Those are all good questions that are relevant to most people. And then the other thing is to ask caregivers, friends, anybody that's around that kind of knows them, you know, hey, where do they normally sit mentation-wise? Again, I'll bring up our dementia patients. Dementia patients, oftentimes, there'll be one thing that they kind of slip on at a time, depending on the progression of the dementia. But it's quite possible that, hey, they're usually really good, really with it, until they get to about, you know, 8 o'clock at night, and then they start slipping a little bit. Those are all really, really good things for us to know so that we can do an accurate assessment on their altered status. Is that altered status a normal for that patient? Is the downward progression throughout the day a normal thing for that patient? And oftentimes it is for dementia patients. AVPU can really quickly tell us what's going on with the patient as far as their level of alertness, as far as, you know, alert to verbal, alert to painful, or just completely unresponsive, right? It doesn't give us specifics, which is where we start to run into some issues, right? We want those specifics in a patient that is altered. Baseline status can be a little difficult to determine in patients that are younger, like children or infants, really. Again, either changing the questions that we're asking to something that the child would reasonably care about at their age, or asking the adults, hey, is this response that we're having from the child a normal response? For instance, if we're dealing with like a 6-month-old, is what this child doing, is that normal for them? Or do they seem really withdrawn? Those are all good indicators, okay? Altered mental status can certainly be a subtle sign that indicates some serious underlying issues. Body system exam and complete history may reveal some important information about the suspected cause. So if we start doing a good, thorough exam of the patient and we realize, hey, they're kind of slurring their speech a little bit, or, they're really just not moving their right side at all. That can tell us that, hey, this might be a stroke that's going on with our patient. Or maybe we take a look at the vital signs and their blood pressure is insanely elevated, like 200s over 100s. Or maybe it's really, really low. That can certainly give us an indication that, hey, there's something going on here. This might be the cause, or maybe this is just another symptom that we need to look at to determine the actual cause. All right. Talk to family members, bystanders, to get kind of that baseline mental status from patients, as well as any additional history that we might be able to get that our patient maybe isn't able to provide to us. Review those medications, any alert bracelets, check out that medical ID on cell phones as well if it's an option. We can certainly even take a look inside billfolds or purses just to see if there's any sort of medical alerts in there as well. Of course, being as respectful as possible in those situations. Asking permission when appropriate. Be sure to accurately document the level of consciousness over time. So we got there and the patient was upright, talking to us, and alert and oriented to person, place, and time. As time shifted and we went through our call, the patient started to only be alert to person and events, not to time, or so on, and make sure that we're documenting that through the call. Consider using our Glasgow Coma Scale to provide precise measurement to patient responses. That's something I'll bring up the specifics of the Glasgow Coma Scale here shortly, but it is a good way to get into the specifics. Yes, our patient is alert, but how alert are they? That's where we reach out to our Glasgow Coma Scale, all right? Diabetes. So, getting into diabetes here. Glucose is a form of sugar. It's the body's basic source of energy, and body cells require glucose to remain alive and create energy. After sugar and carbohydrates are converted to glucose, glucose is then absorbed into the bloodstream. Glucose itself is a fairly large molecule, and it can't pass into the cells without kind of an assistant device. Okay, it's just too big, all right? That device that helps assist is insulin. The pancreas assists insulin when glucose exceeds 90 milligrams per deciliter. Insulin binds to those receptor sites on cells and allows those glucose molecules to pass. Normal glucose levels in the blood are essential to maintaining a normal mental status. So I just said a whole bunch of words. Let's go back through this here just a little bit slower here. So we eat things. We eat donuts, we eat sandwiches, we eat things that have carbs and things that have sugars, whether they're added or natural, it doesn't really matter, right? When our body processes those, they turn into glucose. Glucose is a very large molecule when it's floating through our body. So the process of diffusion is not something that can happen because that molecule is so large. So what it needs is some sort of assistance or key, if you will, to help get into the cells, because our cells are what really matter, right? Our cells need that sugar. So insulin is produced, and insulin helps kind of unlock those cells. It's the key, kind of helps unlock those cells so that we can get glucose into where it needs to be, okay? Insulin is produced when certain levels are reached within our bloodstream to help aid in getting that sugar where it needs to be, and then processed throughout our body, okay? Clicker isn't working. There we go. So patients who are diabetic have some sort of issue within the system that we just described. So either they don't produce any insulin at all, they don't produce enough insulin, or somehow they have become resistant to the insulin that they do produce. There's some sort of issue with that system. This is kind of a fun fact. It's not super important for this particular class. I'm not going to ask you a question on it per se, but National Registry might. The isolates of Langerhans is where exactly insulin is produced within the pancreas. In my class, the exams that I give, typically we're just asking where is it produced, and it's the pancreas. Getting a little bit more focused, isolates of Langerhans is exactly where it's produced. Okay. This is everything that I just mentioned, explaining kind of that we need an ability to get the glucose where it needs to be. That's where insulin helps us out. All right, it's just explaining it again. Type 1 diabetes is where pancreatic cells aren't functioning appropriately. Insulin is not secreted normally. There's too little insulin to transfer circulating glucose into cells, and synthetic insulin is typically prescribed to supplement inadequate natural insulin. So we've got a patient. Patients have a pancreas, but for whatever reason, that pancreas just is not working appropriately. Either it's not producing any insulin or it's not producing enough insulin. So these patients are typically monitored very, very closely throughout their lives and are given synthetic insulin. Usually the synthetic insulin is going to be given to them based on how many carbs that they're eating, carbs and sugars that they're eating throughout the day. Okay. Typically, well, I don't even want to say typically, because there's always exceptions to rules, right? But if somebody is going to develop diabetes at a very young age, it's the likelihood of it being type 1 diabetes is high, where just they were born without a pancreas that isn't functioning appropriately. They're born with a pancreas that isn't functioning appropriately. Okay, that's not always the case. There are exceptions to every rule, certainly. But if they're younger, the likelihood of it being type 1 is a little bit higher. Type 2. So this is where the body's cells fail to utilize insulin properly. The pancreas is secreting enough insulin, but the body's unable to use it, and it may be controlled through things like diet, oral anti-diabetic medications, and sometimes insulin. So again, our body has a pancreas. The pancreas, just for whatever reason, isn't working appropriately. Either it's not giving enough insulin, or it's giving enough insulin, but the body's not really sure what to do with it. It's built up some sort of resistance to the insulin. Okay. Type 2 diabetes, again, there's exceptions to every rule. It's not kind of an always thing, but if somebody is going to develop diabetes later on in life, the likelihood of it being type 2 is fairly high. Hypoglycemia is the term that we use to designate low blood sugar. Hypo meaning low, glycemia meaning sugar. It's caused by too much insulin, too little sugar intake, over-exercising or over-exerting, vomiting, or an increased metabolic rate. Okay, there's a lot of different reasons why somebody's sugar could be out of whack. Right. So oftentimes the stories that we hear is that this is maybe a new diagnosis and the patient isn't quite great yet at regulating their sugars, not knowing how much insulin to give or not understanding the process or the amount of monitoring that needs to take place between the two. Sometimes, hey, they started a new diet, they're trying something new, and based on that new diet, they either have an increased metabolic rate, or they're over-exercising, or again, just not calculating their carbs to insulin ratio correctly, and now they're having issues. It could be something like, hey, they've been really sick lately, and again, either aren't eating enough, or you know, when people are sick, blood sugars do some funky things to try and compensate for the illness. So it's quite possible that they did everything correctly. Their body was just doing some funky things to try and compensate for being sick, and now they've gotten some low sugars. It matters, but it's not always super critical for us to know why it happened. The why is not nearly as important as the it's happened and now we need to deal with the situation. Okay. Hypoglycemia can certainly lead to altered mental status, unconsciousness, and possible permanent brain damage. So we do need to correct this problem as quickly as possible. All right. Onset is rapid with hypoglycemia. Let me say that again. Onset is rapid with hypoglycemia. I said it twice. That must mean that it's going to come up again. Okay. That would be a wonderful thing for you to write down if you're taking notes. Other symptoms that we might see: abnormal behavior, mimicking kind of a drunken stupor, pale, sweaty skin, tachycardia, rapid breathing, seizures, as well as getting a low reading on our glucometer. Quick replenishment of blood sugar is critical to the outcome of our patient. Oral glucose is often used, so we've got our oral glucose medication that we're going to administer buccally to our patient. So remember, even though it says oral glucose on it, we're not giving it as an oral medication. Yes, it goes in the mouth, but oral medication implies that you're swallowing it and it's going to be digested. We are not going to have our patients swallow a whole tube of oral glucose. The idea is that we're going to administer it to them, and then they are going to let it sit in their mouth, a tab or two of it sit in their mouth, so that it is then absorbed through their mucosal membrane. They kind of stick that into their cheek, and it's absorbed through that membrane, as opposed to having to be digested and then absorbed through their intestines. The outcome is a lot faster. Okay? We can also give our patients just pure sugar. Say they've got some soda or candy bars or something like that lying around. We can certainly give them those, and they can eat that, and eventually it will raise their blood sugar. If they're not able to protect their own airway, that's when we can give glucagon, and we'll talk about glucagon a little bit more in a minute. Hyperglycemia is high blood sugar. High glycemia, sugar. It can be caused by, again, a lot of different things. Bodies may be unable to produce insulin. Insulin injections may be forgotten or insufficient. Other things like infection, stress, dietary intake can all be indicators. Again, people that are managing their diabetes sometimes just make miscalculations in how much insulin they were supposed to take. Maybe they figured out a meal, like, hey, I'm going to be eating, XYZ meal today. They calculate the amount of insulin, and then by golly, the neighbors stop over with a cheesecake, and they go, oh my gosh, I love cheesecake. And they have an additional intake that they weren't expecting, and therefore it kind of bumps their sugar up a little bit. Now, there's also a lot of people out there that do not manage their sugars, or they think they're managing it, so they just kind of do whatever they've always done, but in reality it's not actually managing it, and their blood sugars end up getting really, really high because of it. Regardless of the situation, again, the why isn't nearly as important as this is what's happening, therefore we need to do XYZ. Okay. Hyperglycemia is a slow development. Hyperglycemia is a slow development over a couple days or weeks. Another really great thing to write down if you're taking notes, all right? It's a slow development. Signs and symptoms include things like chronic thirst and hunger, increased urination, nausea, dehydration, okay? The cells of the body slowly starve due to glucose that's not able to enter the cells from the blood. Okay, so there's an issue. For whatever reason, the sugars are not able to get into the bloodstream appropriately, or into the cells appropriately, and it creates increased blood sugar readings. Starving the cells, starving cells, burn fats and proteins in a way that produce excessive waste. And that's something generalized rule across the board with our body, is our body always has a set way of operating. We need oxygen, we need sugar, etc. If we don't have those things, it's not necessarily the end of the world. Our body is really good at compensating in different ways, but there's going to be a byproduct that's negative, and eventually that negative outcome or negative byproduct is going to start causing issues. So very, very, very same or the same thing that's happening with this. Our bodies can function, but it's going to start building up excessive waste, which are going to start causing some problems. So those wastes build up and combine with dehydration to cause diabetic ketoacidosis, otherwise known as DKA. So signs of DKA include things like profound altered mental status, shock caused by dehydration, and then rapid breathing, as well as an acetone odor on the breath. Okay. So we're going to assure that our scene is safe. We're going to perform our assessments. We're going to perform primary, secondary, etc. We're going to determine that our patient has an issue with altered mental status, and we're going to investigate that suspicion further by doing a complete history on our patient, doing a complete set of vital signs on our patient, so on and so forth. Okay? Based on our findings, we're going to treat, whether we think it's a stroke or blood sugar or whatnot. Okay. A lot of our patients will have glucometers. We should never be using our patient's glucometer. Okay. And part of this kind of goes back to, not that we're not trusting our patients to utilize them appropriately, but not a lot of people know that these need to be calibrated at often. So they don't calibrate them, and now all of a sudden you're getting readings that are way off. So we want to make sure that we're using our own equipment. Another thing is if like the batteries are dying, sometimes those will give some weird readings as well. So we always want to make sure that we're getting readings off of our own equipment. Each service is going to have a glucometer that might be slightly different. The one on the screen here is a microdot glucometer. Again, every service might have a different manufacturer, or it might have a different model from that particular manufacturer, but they all should have some very similar features. They might have an on button, an on off button. Typically, they will just turn on when you put a strip in them. Sometimes there might be an actual button you have to push to turn it on. So you will have a container full of strips, the glucometer itself, this like computer looking thing. You'll have alcohol wipes, usually some 2x2s or Band-Aids, and then these little orange rectangles are going to be the lancets. Again, lancets come in a lot of different shapes and sizes. All of the ones that we use are going to be like the one and done lancets. I know you can get ones that have like, typically you'll see them with patients that are checking their blood sugar on a regular basis. The like auto injector part is not replaced, like it is multi-use, and then you attach different needles to them. The needle kind of comes off and then you reuse those. We can utilize those, but again, it kind of goes back to like, we've got the equipment, we might as well just use ours. We know it, and we know where it comes from, and we know that it's, clean and so on. Normal blood sugar. So normal blood sugar levels are a myth. No, I'm joking. Well, kind of. So there is a set textbook normal, depending on what you read, what textbook you're reading, who wrote the textbook, so on and so forth. It will tell you different ranges. Sometimes it's 60 is fairly low to be a normal, but 60 to 100. I just read one the other day that was 80 to 130. That was kind of a different range. I'd never seen that one before as a normal. 70 to 120 is fairly common. 70 to 110 is fairly common. For this class, Normal is going to be 60 to 120. Now, I know what you're thinking. Oh, this class, that's great, Mallory. I can do that. But guess what? I have to take and pass the National Registry. So what's the National Registry going to ask me? Well, to answer that question, the National Registry is going to give you extremes. Okay, it's going to say your patient is having XYZ symptoms and their blood sugar is 50. What's the problem? 50. Okay. Or they're having XYZ problems or XYZ symptoms and their blood sugar is 350. Okay. So you're not going to need to know an exact, like, oh, it's, 121. That must mean that they're hyperglycemic. A lot of it will kind of come back to the symptoms or the onset that the patient is experiencing. Okay. All right. For this class, 60 to 120. Another thing to mention with this is patients and people, I should say, not just patients, but people get used to whatever their reading is or their normal blood sugar is. We all have those set normals throughout our system. What's normal for me is not what's normal for you. We're all different in that way, but our body all has a set normal for different things. So blood sugar is not unique in that way, right? Same thing with pulse, same thing with blood pressure. We all have internal normals for that. So it's always a really good thing to ask the patient if they know what they typically run as far as blood sugar. If you have a patient that's diabetic and you think that's why we're being called, is it for a diabetic problem? They will probably know what they run, okay? And think back, when was the last time you had your blood sugar checked? Even if you're not a diabetic, you maybe went to a clinic and they maybe said, hey, this is what your blood sugar is. You might have a general idea, okay? That's fine. So always ask your patients, hey, what do you normally run blood sugar wise? Sometimes they'll say, oh, it's normally in the 250s. Okay, we have a new normal for this particular patient. So that normal is in the 250s. We get a reading that's 120. 120 is still technically within the quote-unquote textbook normal ranges, but that's low for our patient. So maybe the signs and symptoms that our patient is experiencing is associated with low blood sugar. Okay, so we want to make sure that we're treating the patient. We're not just taking our textbook knowledge and treating the textbook, right? Treat the patient. All of our glucometers have a maximum and a minimum. So at some point you may get a blood sugar reading on a patient where the glucometer reads HI for high or LO for low. It really depends on the device. They all kind of have their set ranges. Typically that set range is going to be either 500 on the high end or 15 or 20 on the low end. But again, every different glucometer is just a little bit different. I've had some that only go down to about 30. I've had some that have gone up to 600. It really just depends. Okay. So have a general kind of rule of thumb as far as what yours is, but know that low is really bad and high is equally bad, just different directions. And I kind of talked off the slides a little bit here, so I'm just kind of reviewing and making sure that I'm not repeating myself a whole lot. Make sure you're giving that oral glucose buccally. So again, just put a little bit inside their cheek, in between their teeth and their gums, and then have it let it like sit there for a little bit so it absorbs that way. Consider ALS, especially if you've got a patient where you're just not able to get those blood sugars up, or they've got really high blood sugars. Consider ALS as well. Big thing with oral glucose is just making sure that your patient's able to swallow, that they can protect their airway. That's the big one. Just to review, hyperglycemia has a slow onset. Hyperglycemia has a slow onset. It's going to be days or weeks. Hypoglycemia is going to come on pretty quickly. Hyperglycemia, you've got warm, red, dry skin. Hypoglycemia, you've got cold, cool, clammy skin. Hyperglycemia, textbook says has kind of an acetone breath. Now, I've heard this from a lot of people that they've smelled it and experienced it. I apparently have horrible sense of smell. So I have never come across a patient that smells like this. But like I said, I've known a lot of really reliable, respectable medical providers that are like, oh yeah, that you can totally smell it. So keep your noses open when dealing with your patients. It's quite possible that you will smell kind of an acetone or more of a sweet smell on your patients that have really high blood sugar. But don't feel bad if you don't smell it. Patients with hyperglycemia also have some different, or might have some different breathing. It's called Cushmal respirations, and it's kind of a really fast, really deep respiration. They also are, excessively thirsty, as well as, have excessive urination too. I don't agree with this particular slide. In fact, every time I come across it, I think to myself I should change it, and then I forget that I need to change it, and then we come across it again, and I think this is the exact same thing. But this says that oral glucose is recommended for anybody with diabetic emergency, whether it's hypo or hyper. Now, no, I completely disagree with this. I think most people in the medical field would also disagree with this. If your patient is experiencing symptoms of low blood sugar, regardless of the number, yes, give them oral glucose. But if our patient is experiencing symptoms of high blood sugar and we get a reading in the 300s, don't give them sugar. All right, we should have the ability as EMT basics to clinically think through these problems and determine whether or not our patient is experiencing signs and symptoms of low sugar or signs and symptoms of high sugar, regardless of what that number is reading. Okay. Some other causes of altered mental status. If brain function is upset by injury, infection, or disease, the brain's electrical system can become irregular. So we talked a little bit about this already, that, if our patient gets, hit really hard and they've got like a traumatic brain injury or something, we might see some differences in their behavior or their mental status. That is, it's obviously it's not normal, but it's a normal symptom of getting trauma to the brain. Irregularity can bring about sudden changes in sensation, behavior, or movement called seizures. And I think we go a little bit more in depth with seizures here in just a second. There are different types of seizures that patients can have, and those different types of seizures all have different causes. The other thing is, depending on where the seizure is happening within the brain, kind of dictates the different, the different symptoms. So some seizures, there's no external movement. In fact, the body is very still, and the mind just is kind of going through its own thing or going through its seizure. Those are called absent seizures. Or you can go through like the grand mal seizures, where your body is very active, and it's more of what you would think of when someone's having a seizure. You can also have certain parts of the body affected instead of the whole body. Maybe it's just one arm, or maybe it's both legs, or one side of the body, and it all kind of goes down to where this is happening in the brain. Oftentimes seizures have no warnings. Sometimes they do. Patients sometimes will have an aura, which is kind of a little bit of a warning sign, but very often they don't. So that is one question that we do like to ask our patients that have had seizures or have a history of seizures is, did you get an aura, or do you get auras? That way we know or have a little bit of warning if there is a seizure or another seizure that's going to happen. Sometimes they'll have like dogs or service animals. Usually it's a dog that can detect when they're going to have a seizure. It's kind of cool. Dogs are awesome. I say that. My dog is actually being kind of a nuisance at the moment, but dogs are awesome and can detect a lot of things medically, which is really cool. Seizures have 3 phases. We've got the tonic phase where the body is rigid up to about 30 seconds. Breathing may stop and they also might lose bowel and bladder control. Notice how I said might lose bowel and bladder. The reason I say that or emphasize that is because sometimes you'll get people that are like, oh, well, they didn't lose their bowel and bladder, which must mean they're faking. No, absolutely not. That's not how that works, okay? Colonic phase, the body jerks violently anywhere from up to 2 minutes, we should say. Sometimes it's very quick. Other times it's very elongated. They do it for several minutes. It really just depends on the seizure and what's causing it. Patients may foam at the mouth a little bit. They also might become a bit cyanotic as well. Post-ictal phase is where the convulsions stop. Consciousness is starting to be regained at this phase, but the patient may kind of have some persistent drowsiness as well as being, a bit violent or slightly confused. This is kind of where the body is resetting, so it's kind of just doing a little bit of a reboot, all right? Think of like waking up after a really intense nap. You're like, whoa, where am I at? What even happened? What day is it? And you kind of go through this little reboot essentially. And sometimes it's very quick. People kind of go, wait, what? Oh, I must have had a seizure. And they come out of it very quickly. And other times it takes them a minute. And I'm sure, again, kind of draw back on your personal experience a little bit. How many people do you know can like wake up from a nap instantly and just start functioning? And then how many people do you know are like the complete opposite, that are like, you know what? Give me like 30 minutes before you ask me anything, because I just have to like breathe for a minute, or until they get their caffeine or whatever the situation is, right? So it's very similar. Everybody's just a little bit different when it comes to coming out of seizures, okay? And it all has to do with that brain function and how intense the seizure was as well. The most common cause of seizures in adults is actually the failure to take prescribed anti-seizure medications. So that's another really good question to ask if you've got a patient that is that has had a seizure. It's a good one to ask. Hey, have you had this before? Have you been prescribed any medications? Have you been taking those medications? And good questions to ask. Some other causes, hypoxia, stroke, traumatic brain injury. Pediatric seizures are a little bit different. The most common cause with pediatric seizures, typically we're talking infants, is going to be a really high fever. So that's another thing. If you come across an infant that's seizing, we definitely want to make sure that we're getting good, adequate temperatures on them. Also remove that restrictive clothing if they've got any on them. Ask about, illnesses, past illnesses. Okay. Kids that are kind of in their adolescent stage, sometimes will just have a random seizure. Their body is growing too quickly. They'll hit like a huge growth spurt overnight, and their body will just kind of, or their brain specifically, will just kind of do this reset and have a seizure. Oftentimes they have one once and then they never have one again. So that is something that I'll mention, especially if it's a pediatric seizure. I'll talk to parents if we've got a second to talk. I'll talk to parents and let them know that, like, hey, just because your kid had one seizure doesn't mean they've got epilepsy, or doesn't mean that they've got this lifelong disease that they have to live with. There are other causes. We don't have the knowledge or training or equipment to determine what that cause is, but just know that this isn't necessarily the end of the world, right? Also, if they do have something like epilepsy, there are a lot of medications that they can take for it and so on. We've got a question here. If they didn't take their seizure medication that day, do we ask medical director if we can assist with taking it so it doesn't occur again? That is certainly something you could ask if they've got their seizure medication. If they haven't taken it, usually some good follow-ups are like, why didn't you take it? Sometimes it's, hey, I just forgot and it's been a busy day. In those instances, yes, absolutely. Or, honestly, because it's a prescribed medication, if the patient feels comfortable just taking it, you don't necessarily need to call medical direction, as long as they're taking the prescribed amount. and the patient's comfortable in doing that, okay? Other times, though, certain adults will just say, I don't like the way that it makes me feel, so I haven't been taking it. In those instances, they might not be willing to take it. So, you'll recommend that, obviously with all of these patients, you're going to recommend that they go to the hospital. Other patients, maybe they just had their medication decreased, or, they just started a new medication because of certain side effects. So it may not be that they just didn't take it in general, it just might be that there's an issue with the medication configuration. Seizure medications, you kind of have to have a special amount, right? And they don't really know what amount that is until they start messing around with those medications a little bit. So we do get that fairly regularly, where we'll have a patient that's like, oh yeah, I just got off of one, I'm starting another one, and they're messing with my doses, and so now I'm having seizures all the time because they can't get the doses right. But yeah, excellent question. Thank you. Yes, if they want to take their medication, certainly you can, if it's prescribed, certainly you can allow them to do so. Another thing to kind of bring up with this too is that if patients are going through issues where they're having a lot of seizures, oftentimes they've been to the ER, they're in communication with their doctors, they know that this is happening because they can't get their their medications correctly or something, and they don't want to go to the ER. We strongly recommend that they do, but another ER bill, an ambulance bill, when the end result is, hey, talk to your primary care provider, isn't always the most helpful thing. So in those situations, we try and talk to the patients, see kind of where they're at, why they don't want to go to the hospital. Is it something that they've, thought through? They've heard all of the pros and cons of going versus not going. And ultimately, if they're alert and oriented, they can make, and an adult, they can make their own decisions. One thing that I will say is that if they don't want to go to the hospital and they're just going to sit at home for the rest of the day, see if they can have somebody come over and hang out with them for the rest of the day, or for at least a couple of hours, whether it's a family member or friend or whoever. They can come over and just kind of keep an extra eye on them in case they have another one. Some other causes of seizures: toxins, hypoglycemia, brain tumors, brain defects, infections, etc. There's a lot of different things. Anything that can kind of mess with your brain can certainly cause a seizure. Epilepsy, measles, mumps, eclampsia, heat stroke, etc. can all cause some seizures as well. Epilepsy is an umbrella term that's used to describe multiple seizures of unknown cause. It may be present from birth, so something that they were born with, or it may develop later on in life due to injury or surgery. But yeah, it's just kind of that umbrella term. It's important for us to be able to describe the seizure to the emergency department. So things that we should be asking with all of our patients that have experienced a seizure is, when did it start? How long did it last? If there was somebody there that was able to tell us about it, what did it look like? Was it the whole body or just one arm that was shaking? Were they shaking at all, or was it more of an absent seizure? Did you feel it coming on? Was there an aura? All of those questions are really good ones to ask, as well as, the medication questions. Are you taking medications? Did you take your medication? Other things like, are you under a lot of stress lately? Have you been sick lately? Those are all wonderful questions to ask, or things that could cause seizures. If we are there when the seizure occurs, and I will say it's likely that you will not be there when the seizure actually occurs. Typically, you'll get called by the time you get there, the seizure is stopped, and you're there for more of the post-ictal phase. But if you're there when the seizure occurs, we're going to lay the patient flat on the floor or ground, loosen any restrictive clothing. So if they've got, like a necktie on, we're going to loosen that up or take it off. Unbutton their collar, zip down their hoodie, whatnot. Just loosen up that clothing a little bit. Remove any objects that might harm the patient. Necklaces oftentimes will get kind of twisted or get really tight, so we'll try and loosen those or take them off. And then our job is just to prevent further injury. So we're not trying to hold them down, but if they're repeatedly kind of hitting their head, we're going to put a pillow underneath their head. If they're near a staircase, we're going to ensure that they don't fall down that staircase, etc. Okay. If they do have like a vagus nerve stimulator, we're going to allow the family members to apply that device. If they've got a prescription already for, say, like rectal diazepam or something like that, again, the family is in charge of that. That's something that's out of our scope of practice. And as an EMT basic, you cannot give any rectal medications, so you are not allowed to assist with those either. After convulsions have ended, we're going to protect the airway. If the patient's cyanotic, we're going to give them oxygen. We're going to treat any injuries that they may have gotten, usually things like small lacerations or abrasions, and then we're going to transport to a medical facility, and we just talked about refusals with these patients as well. I went backwards, wrong way. There we go. We don't ever want to place anything in the mouth of a patient that's actively seizing. That used to be a thing where you didn't want the patient to like bite down on their tongue, so you'd shove something into their mouth to prevent that. We don't do that anymore. If they have 2 or more convulsive seizures in a row or a single seizure that lasts more than 10 minutes, it's classified as status epilepticus. This is a high priority emergency requiring immediate transport to the hospital. If you have access to ALS, you certainly should be calling them. Typically, in this situation, as an ALS provider, we will chemically sedate the patient. Typically, we will also intubate this patient as well. So we'll sedate and paralyze and then put a breathing tube down their throat. Because remember, when they're seizing, oftentimes they're not breathing. And if they are breathing, usually it's not adequate enough. So we sedate and paralyze them specifically to be able to control their airway. What we do has no effect on the actual electrical seizure that's happening in their brain. We can stop the body movement chemically, but that doesn't stop the brain stimulation that's happening. Simple partial seizures involve tingling, stiffening, or jerking of one body part. So again, one arm or one leg that's seizing. It is still a seizure that's happening. It's just affecting different parts of the brain. We kind of talked about these. Like I said, I don't really want to repeat myself too much. Just know that there's different types of seizures. Depending on where it's at in the brain, kind of dictates what's going on the outside of the body. Stroke. So stroke is the death or injury of brain tissue from oxygen deprivation. Ischemic stroke is caused by blockage that occurs due to a clot or embolism obstructing an artery in the brain. And hemorrhagic stroke is caused by bleeding from the ruptured blood vessel in the brain. So we do see both of these. I will say ischemic stroke is a bit more common in my experience, but we do see both of these in patients. Again, because we're dealing with the brain, the symptoms that we get from the stroke are often dependent on what's happening or where it's happening in the brain. So say there's a blockage or ischemic area on one side of the brain, that one side of the brain will have a specific set of symptoms that we will see. Now, I don't know what those specific set of symptoms are in relation to each little section of the brain or how bad the ischemic area is. In EMS, we know the generalized symptoms, okay? Very rarely do we know the specifics. And that's fine, right? It's not our job to diagnose that, hey, they had a stroke in this one little section of their brain. That's the doctor's job, okay? Ultimately, for us, it doesn't really matter where the stroke is at. It just matters that, hey, they're having a stroke, and we need to follow XYZ protocol, okay? One-sided weakness or hemiparesis, difficulty speaking or inability to speak, headache can be caused by that hemorrhagic stroke, deviation within the eyes, inability to recognize parts of their own body, aphasia, the other one, aphasia with a G, are all very common signs and symptoms of strokes, okay? So Difficulty speaking is aphasia with an S. They sound the same, they're spelled different, aphasia and aphasia. Deviation of the eyes, this is where the patient will always drift their gaze off to one side or the other. That one's a really interesting one to see, and honestly can be a little difficult to pick up on, especially if they're looking at what appears, if it appears that they're looking at a person or at an object or something like that. It can be a little difficult to pick up on that one, but it is very interesting when you see it. Inability to recognize parts of their own body. So this is something we call neglect or denial. This one is very weird as well. I've only seen it a couple of times, and it's in reference to a very specific part of the brain that's affected, and I don't remember which part of the brain that is, and that's okay. But you'll ask a patient, you'll hold up their hand in front of them and say, whose hand is this? And if it's, say, on the right side of their body, they'll be able to say, oh, that's a weird question, but that's my hand. Okay, no worries. Now we'll do it on the other side, and we'll hold it up in front of them, the other hand, hold it up in front of them on the other side of the body, and we'll go, whose hand is this? And they'll look at it and they'll go, well, that must be your hand. And it's like, oh, well, that's interesting. And they essentially just don't recognize one part of their body. It's very interesting. They can do the same thing with their legs as well. Typically, we use hands because it's right there, a little bit easier, but they'll do it with their legs too. So aphasia is the general term for difficulty communicating. You can also have difficulty swallowing as well. Expressive aphasia is where the patient knows what they want to say but uses the wrong words. And receptive aphasia is the patient can't understand you, so they respond in ways that don't make sense. So expressive aphasia. They know what they want to say. You asked them a question, what's the day today? And they know they want to say Tuesday. But instead, they just cannot get the right words. So either they're just going to struggle trying to figure out what the right word is to say, or they'll say the complete wrong word. Like, what day is today? Hot dog. That's not quite the right answer, is it? Really frustrating part of this is the patients can hear what they're saying, and they can process that what they're saying doesn't make sense, but they don't have the ability to explain that they know that it doesn't make sense. Okay. Receptive aphasia. So this is the where the patient cannot understand you, so they respond in ways that don't make sense. So imagine somebody talking to you in a different language. Pick a language you know nothing about. Tagalog. I would be shocked if you guys knew Tagalog, right? If you do, awesome. But say somebody asks you a question in Tagalog, and you have to respond. What are you going to say? Just pick a random word, essentially, right? You're going to say, I don't understand, or you're going to say, today is Tuesday, even though they asked you what you had for dinner, right? That's the receptive aphasia. They just cannot understand you, so they're going to respond in a way that doesn't make sense, or they just won't respond. TIAs. So a TIA is a transient ischemic attack. The patient exhibits signs of stroke that resolve within 24 hours. That is the only way to know if it is a TIA, is if it resolves within that 24 hours. Oftentimes, patients will have a whole bunch of TIAs, one right after another. Sometimes they'll have one and never have one ever again. But oftentimes they will have those multiple TIAs. Very interesting to see those resolve kind of in front of your eyes. In those situations, you definitely want to note, hey, the symptoms resolved at 7:22 p.m. or 1922. What's going on with TIAs is that there's small clots that temporarily block circulation to parts of the brain and cause those stroke-like symptoms. So it's essentially an ischemic stroke that's happening, but the clots are so small that either they dislodge and pass themselves, or something comes along and kind of breaks them up a little bit or whatnot. Anyways, they resolve on their own. That's a TIA. They do say that, TIAs are kind of the warning strokes. It is technically a stroke, but the warning strokes where, the big one is coming. And that's very, very true. Oftentimes, these small clots are being caused by something. What would be a good example? Like heart problems. If you've got AFib. It's an irregular heart rhythm, but because the heart rhythm is irregular, it can cause some small clots. So say they've got AFib that causes these small clots, and now they've had TIAs and they just ignore it. It's fine. That like old farmer mentality of, well, it resolved, so it must not be that big of a deal. And then all of a sudden they have a massive full-blown stroke that's detrimental. So very important that even though symptoms resolved, we still go to the hospital, still figure out what's going on with their system, and potentially get them on some blood thinners. You need to know how to do one complete stroke scale. Every service is a little bit different as far as which stroke scale they prefer. Sometimes they leave it up to the providers being you. Other times they tell you which stroke scale they prefer. Cincinnati's stroke scale is kind of like the meat and potatoes. It's widely accepted all over the place. It's kind of the generic equate stroke scale, okay? There's 3 parts to the Cincinnati stroke scale. There's facial droop, there's verbal response, and there's one-sided weakness. And we ask questions and have them do things based on those 3 things. Fast ED score is another one that's very common. You'll see those. That one gets a little bit more in depth with like denial, neglect, eye deviation, is the patient on blood thinners, etc. I don't have that one memorized. My service does utilize it, but we have an app that we use that spits out a number at the end of it. Anyways, so you need to know at least one. I do recommend Cincinnati Stroke Scale to start, especially if you don't know what your service recommends. There is like an NIH scale in hospitals. It's a little bit more in depth, so pre-hospital, we tend to stay away from that particular one. Not that it isn't a good stroke scale, it's just a lot more in depth, and we tend to be very abridged with how we do things. So, Cincinnati Stroke Scale, and feel free to follow along, my friends. Can you put your arms out in front of you? And feel free to keep your eyes open for this. We're going to supinate our hands. So the palms of our hands are going to be facing the sky. Supinate our hands, and now close your eyes. We're going to have them do that for about 10 seconds, and it usually is very obvious within the first second or so whether or not this is going to be positive. If there's any sort of droop or inability to hold up that one hand, that is going to be a positive sign for a stroke. The next thing we're going to have them do is say a phrase. The phrase does not matter. It is not supposed to be a tongue twister, so don't have them say anything crazy, okay? For me, usually I'll ask, can you say the skies are blue in whatever town we're in? And they are able to say it back typically. Now, if they're not able to say it back, if they have a hard time processing what you're asking them to do, or they slur, all of those would be positive signs of a stroke. Now, slurred words can be difficult to detect. If your patient doesn't have teeth or don't have their dentures in, slurred speech can be normal variant of what's going on because they don't have teeth. So we have to kind of take that into consideration, okay? One thing I will say is that we do like to utilize family members for this, or somebody that knows the patient, it might be a caregiver, for this, and say, okay, did that speech sound normal to you? And sometimes they'll say, oh yeah, they've always struggled with their S's, or hey, they don't have their teeth in. That's pretty much how they always sound when they don't have their teeth in. That's fine. We can take that into consideration, okay? The next thing we're going to have them do is smile. And I'm not talking like picture perfect, slight smirk smile. We want like a big, cheesy, I want to see all of your teeth type of smile, okay? Big, let me see your teeth smile. What we're looking for is not that they have all of their teeth, but we're looking for symmetry on either side of their face. Are they able to get both sides of their smile up? Are they using their muscles appropriately on either side of their face? If they're not, that would be a sign of stroke. Other symptoms, and these can all fluctuate: confusion, dizziness, numbness, weakness, impaired vision, high blood pressure, difficulty respirations are all kind of signs and symptoms, as well as this long list as well. We do like to check pupils on strokes. If there are unequal pupils, the likelihood of it being a hemorrhagic stroke is a little bit higher. But again, we don't have like a definitive way to diagnose ischemic versus hemorrhagic in the field, which is why all of our stroke patients or suspected stroke patients will be getting a CT scan when they get to the hospital. When we are dealing with a patient that has a stroke or we think is having a stroke, communication is huge. These patients, we don't know if they can, well, sometimes we do. It is possible that they're not understanding the words that you're saying, right, with that aphasia, expressive aphasia, or receptive aphasia, excuse me. But we still want to talk to them. We want to reassure them. We want to let them know what's happening, especially if they're not able to communicate very well. They get very, very anxious and nervous, and it's a really important part of our job to talk to them and explain, based on what we're seeing, we think you're having a stroke. I'm going to call the hospital and let them know that we think you're having a stroke. We're going to take you to XYZ hospital. We're going to get you ready in the ambulance a little bit. Some ambulances will have hospital gowns already, and that'll be a part of your stroke protocol, is to put them in a hospital gown. Sometimes it'll be written in your protocols to take off any jewelry that they have. So you'll put those into a little bag for them. What else? You want to make sure that you get a last known well time on your patients. That's huge with stroke care. There's medications that the hospital can give, but they can only be given within a certain amount of time from the onset of the symptoms. So if you have a patient that woke up at 8 in the morning and noticed that they had signs and symptoms, their last known well time is not 8 in the morning. The last known well time is 10 o'clock at night when they went to bed just fine. If they didn't wake up until 8 a.m., we have no idea when those symptoms started. Now, if they went to bed at 10 p.m. but woke up at 3 a.m. to use the bathroom and they felt perfectly normal at 3 a.m. to use the bathroom, that would be their last known well time, okay? And it needs to be an exact time, not 3 hours ago. No, it needs to be, this started at 4 p.m. in the afternoon or 1600, okay? We also need to get a blood sugar because remember, blood sugars, signs and symptoms of that can mimic stroke as well. So we want to make sure that we're getting blood sugars, as well as asking questions on any alcohol intake or drug use that may have been going on, okay? I like to let my patients know, give them just a little bit of a window into what's going to go on when we get to the hospital. This is something that will be unique to every hospital. The ones I've worked with, typically instead of going into an emergency room, you'll go straight to the CT scanner. So I'll let the patients know, hey, when we get to the hospital, we're actually going to go past the ER into a CT scanner. It's going to look a bit odd, a little bit different room. The bed's pretty narrow. It's going to be uncomfortable for a minute. They're just going to take a picture of what's going on with your brain. There's going to be a lot of nurses in the room, maybe a doctor, maybe like a radiologist. They might ask you some questions right away, but the goal is to get that picture taken as quickly as possible. So things are going to be moving pretty quickly. From there, they'll get you onto the hospital bed and your nurses will take over and take you back to the ER room. Okay, and that's where you'll meet your doctor and so on. So if I know what's going to happen when we get to the hospital, I like to give them a little bit of a heads up. That just kind of helps with the anxiety of the unknown. Okay. If they can't maintain their own airway, certainly we are going to maintain the airway for them. We're going to administer oxygen as necessary and transport to the appropriate level of care. We talked about that. Dizziness and syncope. So dizziness and syncope can be indicative of serious or life-threatening problems. Oftentimes we're not able to diagnose why they had syncopal episodes. And a syncopal episode, let me go back just a little bit. Syncopal episode is when somebody passes out. So we may not be able to, figure out what the reason is, why they passed out, but, certainly we'll do our best to figure it out. So we'll go through, we'll take vital signs. If you've got the ability to do a 4 lead or a 12 lead, you're going to do that on your patient. The other thing is, like, what did you feel like before this happened? What were you doing before this happened? Syncopal episodes oftentimes can kind of look, it might have been like a seizure. So we try and, maybe go down that route a little bit. It might be alcohol related, right? So we ask all these questions to try and figure out what happened with the syncopal episode. Oftentimes it's things like blood pressure or heart related that we can kind of narrow it down to, but everybody is just a little bit different as to why they have syncopal episodes, and each situation is different too, right? Dizziness. So if we have a patient that says that they're dizzy, dizziness can mean a lot of things to a lot of different people, all right? So we try and get a little bit more specific on dizziness. Like, what can you explain that a little bit more? Is it, is it spinning? Is the world spinning around you? Or do you feel like you're spinning? Does it happen only when you move your head a little bit? Like, is it more of like an ear infection type issue? Is it just in general you feel like you're constantly moving, right? We try and just narrow it down a little bit by, what they mean by dizziness. I talked about cardiovascular problems with this. Vasovagal is something that can happen and cause some syncopal episodes as well. This is the vagus nerve stimulation is a vasovagal response. It essentially is a fast drop in blood pressure and heart rate that cause you to pass out. The classic one that we hear about is patients that are constipated will be on the toilet working to relieve their constipation, bearing down, and cause a vasovagal response. You can also cause that response, kids specifically, by putting things in their mouth. So if you're trying to put in like an OPA or something like that, you can cause a vasovagal response as well. But the bathroom situation is one that we hear fairly frequently, especially with the elderly population. Hypovolemic causes, are they dehydrated? Have they been drinking enough? Have they been bleeding? Metabolic stuff, certainly inner ear problems, hypoglycemia, stroke, seizures, as well as alcohol. All of those can have effects, certainly, on dizziness and syncope. Our job in these situations, safety is first, of course, and then to get to the bottom of what's going on. So typically we're asking a lot of questions in these situations. When did it start? How long did it last? What did it feel like? Was it more like this or was it more like that? Have you had similar issues in the past? So on and so forth. Asking all the questions we could possibly think about to try and get down to what could potentially be going on with the patient. Sample history is a really, really great place to start. If you're like, I don't even know what to do. Sample history, what were you doing leading up to this? What were you eating? What's your drinking been like today? Have you been drinking a lot of water? All of those things. Note that when your patients pass out with that syncopal episode, it's quite possible that they had some trauma on the way to the floor. So we want to be also doing those trauma assessments if they hit their head, evaluating for head trauma, and getting a good understanding, especially if somebody is with them. Oftentimes they'll be like, oh, they didn't fall, we just kind of helped them to the ground. Okay, well, what does that look like? Did they hit anything, or were you literally very slowly kind of moving them to the ground? All good questions to ask. All right, that was the end of this chapter. I'm going to go ahead and stop the recording here. Do we have